Hi everyone, Erin Weber here, and as part of this semester in the clinical practicum of the course Care of the Older Adult, we were asked to put together a service learning GNOME project for our clinical site. GNOME stands for the educational planning steps, goals, needs assessment, objectives, methods, and evaluation. I selected to take a deep dive and focus my project on insomnia in the older adult population. As described in our textbook, insomnia is a complaint or disorder that includes one or more of the following: difficulty falling asleep, difficulty staying asleep, waking up too early, or sleep that is non-restorative or poor in quality that results in some form of daytime impairment such as fatigue, irritability, impairment in attention or concentration, or daytime sleepiness. While there are a number of other sleep disorders, insomnia is the most common, with a prevalence of 31 to 38% in adults ages 18 to 64 and 45% in adults ages 65 to 79. Insomnia disproportionately affects older adults and is a multifactorial problem that has serious consequences on physical, psychological, and social health. Numerous factors contribute to the high prevalence of insomnia in older adults, including psychiatric and neurological disorders, medical comorbidities, polypharmacy, adverse effects of medications, substance abuse, decreased sensory input, including visual and auditory, unrealistic expectations of sleep, lifestyle changes from retirement and changes in daily structure, environmental changes including homes to hospitals and care facilities, and psychosocial stressors. Moreover, research indicates that with aging, more time is spent in the light sleep stages and less time is spent in REM and deep sleep. As a result, sleep is more fragmented and older adults often report waking up earlier, prolonged periods of fall asleep, more nighttime awakenings, and decreased total sleep. Insomnia takes a serious toll on the adult population. Chronic insomnia is associated with cognitive difficulties, mood disorders, poor daily functioning, decreased quality of life, increased risk of falls, nursing home placement in older adults, increased risk of cardiovascular disease, increased multi-system biological risks, and all-cause mortality. To develop my service learning project, I used GNOME, which is a model for the community-based educational program or intervention. The 5 steps include G for goals, which are broad and vaguely defined aspirations, N for needs, which refer to the knowledge, skills, and behaviors that are missing in order to obtain the goals, O for objectives, which are specific and measurable, performance or competency-based, M for methods, which are the interventions and processes driven by the objectives, and E for evaluation, or the feedback and assessment related to the success of the methods in meeting the objectives. Although sleep disorders are highly prevalent in the older adult population, those aged 65 years and older, they are not considered an inherent part of the aging process. Based on national goals, this project aimed to increase public knowledge of how adequate sleep and treatment of sleep disorders improves health, productivity, wellness, quality of life, and safety on roads and in the workplace, a goal put forth by the U.S. Department of Health and Human Services in Healthy People 2020. Also, to assess the prevalence of sleep insufficiency and sleep disorders among the U.S. population, a goal of the CDC, and furthermore to raise awareness about the problem of sleep insufficiency and sleep disorders and the importance of sleep health for the nation's overall health, which is a mission of the CDC. As stated by the U.S. Department of Health and Human Services, the public health burden of chronic sleep loss and sleep disorders, coupled with low awareness of poor sleep health among the general population, healthcare professionals, and policymakers, necessitates a well-coordinated strategy to improve sleep-related health. Prior to disseminating my teaching project, although most providers had heard of cognitive behavioral therapy for insomnia, or CBTI, few were familiar enough to feel comfortable applying it. Although insomnia is a common complaint, it is not often the primary reason that patients present to the clinic, and moreover, it is challenging to manage. Therefore, despite the impact on health, it often gets put on the back burner. The general consensus at my clinic was that CBTI was an impractical, time-consuming intervention, and although the providers were aware of the risks, in general, most used low-dose agents such as Ambien cautiously in the older adult population. There was clearly a need to introduce or refamiliarize the clinicians and healthcare associates at this clinical site with current best practice recommendations and provide tools to make implementing these recommendations feasible. I came up with 4 specific objectives for the project. 1. To increase the provider's awareness of the problem of insomnia in older adults. To do this, I provided national data on the prevalence of insomnia and discussed the impact of insomnia on various measures of health. 2. To educate providers on the current clinical practice guidelines. Here I emphasize that hypnotics and sedatives are discouraged as first-line agents, and that CBTI is recommended as first-line therapy. 3. I sought to educate providers on CBTI. I aim to do this by reviewing the 7 steps and providing simple suggestions to discuss with the patient, and by providing resources, specifically trifolds and posters for the clinic. And 4. To increase the application of CBTI at this clinical site, through providing a review on the elements of CBTI in a presentation and providing trifolds that the team members can offer to patients. The challenge in managing insomnia in older adults arises from lack of pharmacologic agents deemed safe, as well as lack of awareness and time to implement non-pharmacologic methods. By and large, all of the sedatives and hypnotics available are on the Beers criteria. That is, they are recommended against, or to be used in caution in older adults. The most recent guideline from the American Board of Internal Medicine as part of the Choosing Wisely campaign says to avoid the use of hypnotics as primary therapy for chronic insomnia in adults. Instead, offer cognitive behavioral therapy and reserve medication for adjunctive treatment when necessary. The American Academy of Sleep reviewed all of the pharmacologic agents used in clinical practice to treat insomnia. And pardon me if I stumble pronouncing some of these, but they reviewed diphenhydramine, doxepin, isoplicone, melatonin, ramelteon, suvexurant, temazepam, tiagabine, trazodone, triazolam, tryptophan, valerian hops, zaleplon, and zolpidem. And all were given a weak recommendation or low degree of certainty in their appropriateness to treat insomnia. The only intervention given a strong recommendation for implementation in clinical practice is CBTI. My approach for meeting the objectives involved providing a readily available educational intervention that could be accessed and referenced now or any time in the future. There are 9 providers at the office, each with a nurse or medical assistant, as well as some auxiliary healthcare and front desk staff, with variable schedules. I figured I could reach nearly everyone by allowing them to access a presentation at their convenience. So I put together a less than 10-minute PowerPoint presentation that I converted to an MP4 file and uploaded as a YouTube video. The presentation reviews prevalence data, the impact of insomnia, and current practice guidelines, just as I have discussed here. Furthermore, it describes the CBTI techniques in detail and provides specific suggestions for the healthcare team members to discuss with patients for each aspect. The presentation format was guided by the recommended features put forth by Dusage to keep the presentation design simple, write succinct titles, use verbal transitions, choose a readable font, stick by the 6x6 rule, state the objectives, use graphics effectively, vary the teaching strategy, and use online tools if appropriate. I also provided the clinic with posters to hang around the office, as well as a trifold brochure to distribute to patients, especially if they feel there is a lack of time to apply CBTI during the office visit. To evaluate the effectiveness of my intervention, I created a SurveyMonkey questionnaire. The first objective was to increase the provider's awareness of the problem of insomnia in older adults. The survey asked, were you aware of the high prevalence of insomnia? The second objective was to educate providers on the current clinical practice guidelines. The survey asked, were you aware that CBTI is considered first-line therapy and pharmacologic agents are to be reserved as adjuncts? As well as, do you use CBTI prior to using pharmacologic agents for insomnia? The third objective was to educate providers on CBTI. The survey asked, was the information about CBTI new or familiar? And objective 4 was to increase the application of CBTI at this clinical site. The survey asked, after this presentation, how likely do you think you will be to implement these strategies in practice, or at the very least, provide patients with handouts? So far, 6 individuals have taken the survey. In response to the first question, were you aware of the high prevalence of insomnia? 5 of the respondents answered yes. When asked, were you aware that CBTI is considered first-line therapy and pharmacologic agents are to be reserved as adjuncts? 3 of the respondents answered yes, 1 somewhat, and 1 no, and 1 skipped. When asked, do you use CBTI prior to using pharmacological agents for CBTI? 5 respondents answered sometimes and 1 always. When asked, was the information about CBTI new or familiar? 1 individual answered somewhat familiar. I've heard about it before but haven't implemented it in practice. 3 individuals answered familiar. They sometimes use the strategies in practice. And 2 individuals answered very familiar. They have used the strategies before and feel comfortable advising patients. And last, when asked after this presentation, how likely do you think you will be to implement these strategies in practice, or at the very least provide patients with handouts? 4 of the individuals answered very likely, 1 likely, and 1 neither likely or unlikely. Although I am pleased with the responses, in order to increase participation, one barrier that I did not anticipate was a firewall on the work computers at the clinic. When I first sent out the email and links, the PowerPoint was only made available via YouTube, and I assumed this would be easier for individuals to access and would prevent problems if recipients had different operating systems. It wasn't until a week after I sent out the initial email that someone notified me of the firewall issue. Therefore, I sent out another email with the PowerPoint with voiceover, as well as notification about the possibility of having to use home devices to access the YouTube if they did not wish to download the presentation. Nonetheless, of the individuals that did opt to take the survey, most answered that they were aware that CBTI is considered first-line treatment, although a majority only implemented the strategies and practice guidelines sometimes, and only 1 individual always used CBTI prior to pharmacologic agents. Encouragingly, a majority answered that after viewing the presentation, the likelihood that they would implement CBTI strategies, or at the very least use the provided handouts that I created, was high. In producing doctoral nursing work, it is important to evaluate domains of practice that have been addressed. There are several of the essentials of doctoral education for advanced nursing practice put forth by the American Association of Colleges of Nursing that were met by this GNOME project. The first is scientific underpinnings for practice, which is demonstrated by the integration of science-based concepts and evaluation of practice guidelines for insomnia. The second is organizational and systems leadership for quality improvement and systems thinking, which is demonstrated by evaluating the current care delivery practices in the clinic and providing education to develop communication skills and processes to improve the quality of care delivered to patients complaining of insomnia in this community. The third is clinical scholarship and analytical methods for evidence-based practice, which is demonstrated by appraising the existing literature and disseminating findings regarding the evidence-based recommendations to improve health outcomes for individuals with insomnia. The fourth is clinical prevention and population health for improving the nation's health, which is demonstrated by targeting current national calls for action, such as Healthy People 2020 and the CDC goals, and reviewing concepts to promote community, environmental, and occupational, as well as cultural and socioeconomic dimensions of health for those suffering from insomnia. And 5, advanced nursing practice, which is demonstrated by educating and partnering with the healthcare team at the clinic to improve the outcomes of patients with insomnia. While I experienced some angst about this GNOME project, overall I was glad to have the opportunity to educate the team members at my clinical site on current practice guidelines and provide educational adjuncts which will hopefully improve outcomes of patients suffering from insomnia in this community. I thank you for your time, and perhaps you will find this information beneficial to your own practice. In the discussion, I have included links to the PowerPoint presentation as well as the handouts that I provided to the clinic if you would like to reference them for your own clinical practice.